For many of our early-stage patients with mycosis fungoides, disease is limited to their skin, and they may experience itching or, in some cases, skin pain or cosmetic issues. So my major focus for these patients is to palliate those symptoms using topical therapies. In my experience, many early-stage patients with mycosis fungoides can be stabilized and remain relatively disease-free using skin-directed modalities. However, once patients have advanced disease with blood involvement, lymph node involvement, or cutaneous tumors, they should be treated more aggressively using systemic therapies that address the disease in the different compartments of involvement. Patients with advanced disease can be difficult to treat and will require long-term therapy. My goal for these patients is to palliate them, managing any symptoms I can control along the way. Clinical practice guidelines from various organizations, such as the National Comprehensive Cancer Network, the European Organization for Research and Treatment of Cancer, and the International Society for Cutaneous Lymphoma, which address the staging and treatment of cutaneous lymphomas, are useful tools. I refer to the NCCN guidelines most often because they really give the framework to think about the therapies that are options for our patients at different points in the course of their disease. But the guidelines are all pretty much in agreement with each other in that they recommend patients be treated with modalities that address the different compartments of their disease. The NCCN guidelines provide helpful recommendations on the appropriate diagnosis and staging of patients, including the use of immunohistochemical staining and molecular tests, PET scanning and bone marrow biopsy, as well as guidelines for flow cytometry and the specific markers that are useful for determining blood involvement. To implement the NCCN treatment guidelines, it's useful to identify where your patient fits on the algorithm in terms of what stage of disease they have. From there, you can look at the different treatment modalities based on their degree of disease and individual clinical circumstances. Other patient and disease-related characteristics, such as comorbidities that your patient may have, can help you determine which treatment options may be the most appropriate. B1 blood involvement is a very broad category that covers a wide range of amounts of circulating malignant cells. For patients in the B1 category who have a high number of circulating cells, just not quite to the level of B2, I would consider treating that patient as if they had B2 blood involvement. But of course, we have to individualize our treatment choices for each patient. I may treat a patient who has a very low number of circulating cells that puts them just outside the B0 category differently than a patient with a high number of circulating cells. We should also keep in mind that the quantitation of malignant cells in the blood can be somewhat variable among patients as well as within a specific patient case. So blood involvement is to some degree a moving target, which highlights the importance of performing regular flow cytometry. The patient who truly has limited or localized skin involvement is the optimal patient to receive exclusively topical modalities or skin-directed therapies. This depends on the patient being appropriately staged with no blood or lymph node involvement. It's also important to continually assess these patients for potential blood involvement or systemic disease, and to consider repeat imaging to assess lymph node involvement. When a patient progresses beyond localized skin involvement, they may still be appropriate for skin-directed therapy, but that may not be enough to address the disease that has progressed to other compartments. That's when I start thinking about systemic therapy. For most patients, we define treatment failure as the progression of disease. They have evidence of progression, either worsening of blood involvement, enlargement of lymph nodes, visceral involvement, worsening of skin symptoms, or potentially large cell transformation of their disease. We document progression using a variety of methods and tools. For skin, we can look at the patient and use tools like the MSWAT, and we may repeat skin biopsies, particularly in patients who've developed tumors or when there's evidence of rapid progression. In my practice, we perform flow cytometry regularly to monitor blood involvement and detect evolution and increase in malignant cells. Finally, we listen to our patients. They may report symptom worsening, like increasing pruritus or skin pain, or they may develop cracking of their skin or other manifestations that the disease is progressing. Of course, there are other reasons why we may discontinue a systemic therapy. For instance, if the patient cannot tolerate the treatment, or they develop new comorbidities that would prohibit us from escalating treatment or continuing to treat with that same agent. But the majority of patients discontinue a systemic treatment because they've become refractory to that agent. Our next systemic treatment choice may depend on a variety of factors, including response to the prior therapies, what disease compartments the patient has progressed in, toxicity profiles, and patient preference.
Indication: POTELIGEO mogamulizumab-kpkc injection for intravenous infusion is indicated for the treatment of adult patients with relapsed or refractory mycosis fungoides, MF, or Sézary syndrome, SS, after at least one prior systemic therapy. Important safety information, warnings and precautions. Dermatologic toxicity. Monitor patients for rash throughout the course of treatment. For patients who experienced dermatologic toxicity in Trial 1, the median time to onset was 15 weeks, with 25% of cases occurring after 31 weeks. Interrupt POTELIGEO for moderate or severe rash, grades 2 or 3. Permanently discontinue POTELIGEO for life-threatening grade 4 rash, or for any Stevens-Johnson syndrome SJS or toxic epidermal necrolysis. 10. Infusion reactions. Most infusion reactions occur during or shortly after the first infusion. Infusion reactions can also occur with subsequent infusions. Monitor patients closely for signs and symptoms of infusion reactions and interrupt the infusion for any grade reaction and treat promptly. Permanently discontinue POTELIGEO for any life-threatening grade 4 infusion reaction. Infections. Monitor patients for signs and symptoms of infection and treat promptly. Autoimmune complications. Interrupt or permanently discontinue POTELIGEO as appropriate for suspected immune-mediated adverse reactions. Consider the benefit-risk of POTELIGEO in patients with a history of autoimmune disease. Complications of allogeneic HSCT after POTELIGEO. Increased risk of transplant complications have been reported in patients who received allogeneic HSCT after POTELIGEO. Follow patients closely for early evidence of transplant-related complications. Adverse reactions. The most common adverse reactions reported in greater than or equal to 10% of patients with POTELIGEO in the clinical trial were rash, including drug eruption, 35%, infusion reaction, 33%, fatigue, 31%, diarrhea, 28%, drug eruption, 24%, upper respiratory tract infection, 22%, musculoskeletal pain, 22%, skin infection, 19%, pyrexia, 17%, edema, 16%, nausea, 16%, headache, 14%, thrombocytopenia, 14%, constipation, 13%, anemia, 12%, mucositis, 12%, cough, 11%, and hypertension, 10%. You are encouraged to report suspected adverse reactions to Kyowa Kirin Incorporated at 1-844-768-3544 or FDA at 1-800-FDA-1088 or fda.gov/medwatch.